Well, first thing, thank you very much to Professor von Braun and Monsignor Sanchez Sorondo for inviting me to give this presentation. And thank you for sharing the session to Professor Singer. What I want to talk about is risk factors in COVID-19 infection. And I want to go straight into the subject by just making two statements beforehand. First, this is a very extensive area of research that has developed over the last 8-9 months. So I want to apologize because I'm going to be very schematic. And secondly, I would like to echo something that all of us understand, and that this crisis, like many others in the history of mankind, has given rise to a myriad of questions of different nature and depth. And for science and technology, in spite of the pain and suffering, as it has been mentioned, it has offered an opportunity to exercise the human ability to acquire knowledge and to generate innovation. And this has occurred at a neck-breaking pace. The only thing we should hope is that this crisis, unlike many others, teaches us lessons that we all agree to apply for many years to come. In relation to what I'm supposed to be talking about, there are three main risk factors which determine the severity of SARS-CoV-2 infections: age, comorbidities, and socioeconomic background. SARS-CoV-2 infections are more severe and produce higher mortality rates in the old, the sick, and the poor. In terms of gender, males are significantly more affected than females. Over the course of the pandemic, a still incomplete picture has emerged about the pathophysiological changes that follows SARS-CoV-2 infection, and with it, an evolving explanation for the connection between these risk factors and cardiovascular morbidity and mortality in this viral infection. At the center of this understanding is the vascular endothelium. The vascular endothelium is this very thin single layer of cells that covers the inside of all our vessels, both arteries and veins. And in each of us, this layer covers a surface of about 7,000 square meters. But for many years, how do I move the slides? I have no idea how to do this. Can I have the first slide, please, first?
This?
For many years, this layer of the inside of the vessel was considered to be an inner surface, a cellophane type wrapper that allows the blood flowing smoothly. It turns out, however, that the vascular endothelium is a highly complex system which actively protects the homeostatic functioning of the vascular wall, of which it is no more than about 1% of its total weight. It releases a number of biologically active factors, most notably prostacyclin and nitric oxide. The complexity of the functions of the endothelium is such that in the last 20 to 30 years, the vascular endothelium has started to be considered an organ in its own right. As you can see in this slide, the endothelium was a late discovery in 1845, and a typical endothelial cell is very thin cell of 0.2 to 3 micrometers thick, and a polycide cell with about 30 micrometers long and 10 micrometers wide. And it accounts for less than 1% of the total weight of the artery. Can I have the next slide, whoever is doing that? This is a typical endothelial cell. You can see the structure of the cytoskeleton in green, keeping the shape of the cell, the nucleus in blue, and a network of mitochondria around. And the next one. And as I said to you, as recently as the late 1960s, the endothelium was considered to be an inert surface. But that's not the case, and very active factors are playing a role, like you can see there in the inside of the vessel, like prostacyclin and nitric oxide, acting on the vascular smooth muscle and on other systems controlling the homeostatic functioning of the vessel wall. Prostacyclin and nitric oxide that you can see there are protective substances which operate in equilibrium with potentially damaging substances, such as oxygen-derived radicals and other pro-inflammatory substances, such as angiotensin II, which is also a vasoconstrictor. Changes in this balance away from the protective mechanisms creates a situation which nurtures and accelerates the development of vascular disease. This unbalanced state is nowadays called endothelial dysfunction, and is a biochemical lesion in which the decrease of nitric oxide production is paramount. It can be measured and predates the appearance of vascular disease, of overt vascular disease, sometimes by many years. The SARS-CoV-2 virus penetrates the body by binding to the angiotensin receptor ACE2, which is part of the equilibrium systems that I have just mentioned. This is a diagrammatic representation of the Renin-Angiotensin system, which has turned out to be so important in determining the course of the disease. Angiotensin is generated from a precursor which is made in the liver into angiotensin 1, which is by a converting enzyme then converted into angiotensin 2, which acts on a receptor. Angiotensin 2 is vasoconstrictor and now is known to produce inflammation, is pro-oxidant, increases proliferation and fibrosis. So when you have a hypertension, for example, there are 2 types of drugs that you can get. The ones that inhibit the conversion of angiotensin 1 into angiotensin 2, and that is one type of drug, or drugs that block the actions of angiotensin 2 on the receptor. In the last 20 years or so, it has become clear that angiotensin 2 is balanced by the production of this angiotensin 1,7, which is transformed from angiotensin 1 by this ACE2 receptor that I just mentioned to you, that is absolutely crucial for viral entrance. Angiotensin 1,7 is the biological opposite of angiotensin 2 and is a vasodilator. It inhibits inflammation, it inhibits oxidation, is anti-proliferative and as antifibrotic. And in this way, it checks the actions of angiotensin 2. The ACE2 receptor, which can be present in blood or in tissues, is widely distributed in the body, most abundantly in the epithelial cells of the respiratory tract, especially in the lung, and throughout the vasculature, in the vascular endothelium of all the cells in the vasculature of our vessels. Besides, the angiotensin CE2 receptor is present in the kidney, is present in the heart, is present in the pancreas, intestine, and in the nervous tissue, both in glial and in neurons. As the virus penetrates the cells, the receptor is internalized, losing its function. The cells are damaged, and the balance in favor of angiotensin II, the noxious angiotensin II, takes place, followed by this self-enhancing inflammation that leads to the so-called cytokine storm, which very often is the most damaging part of the disease. In this slide, you can see how the virus is internalized through interacting with the AC2 receptor. The normal conversion of angiotensin II into angiotensin I is decreased, and then the balance changes in favor of angiotensin II. So there is a very large degree of inflammation. And indeed, in post-mortem specimens from COVID-19 patients, they have shown evidence of a great inflammatory reaction and death of vascular endothelial cells with presence of apoptotic bodies. Moreover, there are also signs of pyroptosis, a highly inflammatory form of cell death combined with signs of necrosis. Can I have the next slide, please? This is micrographs published by Varga recently in The Lancet, showing different aspects of endothelial inflammation, viral inclusions, and cell death in autopsy specimens of COVID-19 patients. The reason why the virus is so damaging to so many organs, therefore, is dual. First, because the receptor is widely distributed, as I told you. And second, because the vessels go everywhere in the body and are themselves damaged. So let's go back to endothelial dysfunction. It is now widely accepted that as we age, the functions of the vascular endothelium deteriorate and the capacity to protect the vasculature is reduced. The balance between protective and damaging mechanisms shifts in favor of the latter, leading to a more prothrombotic and vasoconstrictor phenotype in old. This age-related endothelial dysfunction is enhanced and accelerated by the comorbidities associated with the so-called Western lifestyle, including metabolic syndrome, diabetes type 2, hypertension, and obesity. This is a group of chronic, non-communicable diseases which are chronic and degenerative. These diseases, besides all having endothelial dysfunction, are characterized by having a low-grade systemic inflammation, and both of these factors create a favorable background upon which the virus potentiates pre-existing lesions. Unfortunately, the incidence of these diseases is increasing not only in the developed world, but also in the low and middle income countries, where the middle classes have adopted the Western lifestyle. As a result, these latter countries find themselves in the unenvious situation in which, without having solved the health problems of the underdevelopment, now in addition have to deal with the diseases of the rich. The virus then has hit a large population throughout the world, which is suffering from what should be also recognized as a pandemic, that of the chronic degenerative diseases, which already kill more people than anything else in the world. The combination of chronic degenerative diseases and the coronavirus infection in terms of damage is more than additive. In the rich countries, with notable exceptions, the older people, the ethnic minorities, the key workers who are poorly paid, live in suboptimal housing conditions, eat unhealthy diets, and are less well covered by the health systems, are suffering inordinately. Which brings me to the next point I want to make. In spite of the evident risk of a new pandemic highlighted by scientists for many years, the health system in the majority of the countries of the developed West were woefully unprepared for the emergency represented by the galloping infection. The prioritized interest in curative rather than preventive medicine is responsible for that lack of foresight. This has been discussed extensively, and I hope that it will be also mentioned again during this meeting. I have advocated for many years for a change in emphasis in favor of preventive medicine. During my directorship in the Institute of Cancer Science at the University of Manchester, I tried to create a blueprint for rebalancing all of our work towards prevention rather than treatment, not only of cancer, but also of chronic degenerative diseases in general. Prevention rather than treatment is what is going to deal with the problems of chronic degenerative diseases. If that was the case, and we have been doing prevention, then SARS-CoV-2 would have found a healthier population adequately covered by the public health systems. After much discussion, it is evident that this pandemic is not just a medical problem. It is a medical, a social, and an economic problem which has uncovered inadequacies in our societies. As we have heard, it is likely that soon we will have an effective vaccine, and more and better treatments will follow the use of remdesivir and dexamethasone, the only two drugs for which there is evidence for a positive action in the disease. However, it is clear that the vaccine is not going to be a magic bullet as it is often advertised, and the treatments are proving to be difficult to find. Furthermore, and I think this is very concerning, a significant number of survivors of the COVID-19 have long-term sequelae which we don't fully understand and therefore don't know how to prevent or to treat. With other scientists, I think that the way of dealing effectively with this pandemic is, besides pharmacology and therapeutics, by acting on the causes that have allowed the virus to be so damaging. Our lifestyle seems to be at the basis of it and to be its main risk factor. Interestingly, as I was reading for this presentation, I came across a paper that I had missed on its day and that remains unfollowed in the literature now for 10 years. That paper, and you can see the title in the last slide, points to the fact that endothelial dysfunction is related to socioeconomical background. I think that to continue ignoring the social determinants of disease is to deny ourselves the possibility of fighting effectively this pandemic and others that will most probably follow. Thank you very much.